Everybody knows that this is not going forward. Fracture acetabulum and is difficult to treat, as Marvin Tile has said that it's an enigma, and the enigma is because of its complex anatomy, difficult radiological interpretation, challenging surgical approaches to the acetabulum, and most of the times it is associated with polytrauma, and in Indian scenario it is referred to you after some days. So acetabulum, as you know, it's an inverted Y-shaped structure. It's an inverted Y, and it's an anterior limb and the posterior limb. One anterior limb is called the anterior column. It starts from the superior end of the iliac crest and includes the anterior wall of the acetabulum and extends to the pubic symphysis, that is the anterior column. Then you have a posterior column which starts from the behind and goes to the inferior pubic ramus. That's the posterior. This is the anterior, this is the posterior. Coming to the mechanism of injury. Mechanism of injury is most difficult. It's not a simple fracture, a simple mechanism of injury. It's mostly from the fall from height, or it may be a difficult car accidents, like you have a polytrauma because of the multiple high velocity injuries. You can get a bumper strike to your knees, and you can have dashboard injuries, and you can have a fracture acetabulum. Actually, it depends on how your head is there. So if you are sitting in a car like this and the bumper hits to this area, it will go posteriorly. If you are sitting like this and bumper hits to this part of the knee, it will come out anteriorly. So it depends on the position how you are sitting at the time of impact. Classification, you know, there are various classifications. There is anatomical classification, uterine and judate classification, AO classification, but the most widely used is uterine and judate. So it has elementary types and associated types. Elementary types is posterior wall, posterior column, anterior wall, anterior column, and transverse. It's easy. So if you consider this pelvis, this is a posterior wall, the posterior column, anterior wall, anterior column, and a transverse going from front to back. We'll see in detail how to identify these fractures. Then associated fractures are a combination of the elementary types, that is posterior wall plus column, transverse is posterior wall T-type, it's a further addition to the transverse, anterior column and posterior hemitransverse, and both column fractures. So this is widely used classification for fracture acetabulum. So what is the ideal classification? Should give you exact guidelines to classify all acetabular injuries, give you a precise guideline whether we should operate or not operate. We should consider the impact associated with the injuries on the management and give a prognostic criteria. Thus, we have developed a simplified approach which makes us understand what and whether the fracture involves the anterior or the posterior elements rather than going into individual types. So, this is the protocol. So you see that the fracture acetabulum comes to the casualty. You first, as Mahesh said, that you find out ABCD is stable or unstable. If it is stable, look for associated injuries and then go for X-ray. If it is unstable, stabilize the patient and take them to X-rays. Once you see the X-rays, you first find out whether there is dislocation. You have to reduce the dislocation. If there is no dislocation, then you have to define the fracture lines. And then defining the fracture lines, then you decide whether operative or non-operative. And then also, if it is operative, what are the which approach we should take? Cocker lying back, ilioinguinal combined. So we will see these fracture lines. These fracture lines will tell us whether there is anterior, posterior involvement is there or no. So what are these lines? First, you have to see on an X-ray is teardrop, dome, posterior wall or lip, iliopectineal line, ilioischial line, and anterior lip. So what are these? So these are seen on the X-rays. And teardrop and dome are best in AP, posterior lip, iliopectineal line, obturator oblique, ilioischial and anterior lip in iliac oblique. So judate views are mandatory, anteroposterior views, obturator oblique and iliac oblique. So this is the AP view. See this AP view.